This is Mazen Jodi, Assistant Professor in the Medical College, Baghdad Medical College. I would like to present, by the name of God, this lecture about the principles of medical oncology in breast cancer. Yes. In current practice, three systemic treatment modalities are widely used as adjuvant therapy for early stage breast cancer, and these modalities are: first of all is the endocrine treatment. Second type, it is the anti-HER2 therapy. And the third type, of course, is the chemotherapy. These lines used for breast cancer, whether as adjuvant treatment or also are used the same treatment for the metastatic breast cancer with specific selection accordingly, case by case. Of course, each item of these three types needs an isolated lecture, but I'll try to summarize the most important points regarding these types of treatment. Selection of adjuvant treatment from each one of these types depends mainly on what? On the biologic features of the cancer. That is to say, breast cancer is a term and includes different types of cancer depending on the molecular features and on the immunohistochemistry results, whether hormonal positive, ER and or PR positive, or maybe hormonal negative with or without HER2 positive character. Let's start with the chemotherapy. For the patient of breast cancer. Chemotherapy is used for early stage and advanced stage breast cancer. And in the advanced stage, if we start for the discussion of the advanced breast cancer, that is MBC, metastatic breast cancer, the selection of chemotherapy and the use dependent on specific features when the patient has visceral crisis or rapid progressive disease. In this condition, we use the combination chemotherapy or single agent of chemotherapy. The studies found that single agent chemotherapy is not inferior to the use of combination except in certain situations. Regarding the adjuvant chemotherapy in use of breast cancer, the adjuvant chemotherapy is used for treatment in certain situations, either as first situation when the patient has hormone receptive negative, that is to say breast cancer with negative hormone receptors. So the first one is the hormone receptor negative. The second indication for the patient with breast cancer and the use of chemotherapy is the patient alongside the Trastuzumab. That's to say, the patient has HER2 positive. So with Trastuzumab, the use of the patient breast cancer with HER2 positive cancer. The third situation is the use in the hormonal positive that are hormone receptor positive. But what after the use of the after surgery, we use the chemotherapy in certain situations to be followed by the endocrine therapy. So this based largely on the features such as the anatomic features of the patient, like the tumor size and nodal status, and also on the biologic feature of the cancer, and also on the patient of other health comorbidities and consideration. The use of the chemotherapy in the breast cancer as adjuvant treatment is what is called polychemotherapy. In polychemotherapy, we use more than one agent as combination agent for the treatment of breast cancer in adjuvant condition. Now, the question, what are the goals of chemotherapy in patients with breast cancer? The first goal for the use of chemotherapy in breast cancer is to lower the risk of breast cancer recurrence. So the first goal is to lower the recurrence or the breast cancer recurrence in the patient. The second goal for the use of chemotherapy is to improve the overall survival of the patient. There are many chemotherapeutic agents are used as adjuvant treatment for breast cancer, mainly the anthracycline, but the introduction of taxanes into the early stage of breast cancer, taxanes that include mainly the paclitaxel, Taxol, and docetaxel, which is Taxotere. So the use of these taxanes into the early stage of breast cancer treatment constitute an important advance over the AC alone. So this has an important advance where the use of taxane in addition to the AC, which include the anthracycline with cyclophosphamide. The first report on adjuvant taxane therapy is by the CalGB study that demonstrate that the addition of sequential paclitaxel therapy improved both the overall survival and the progression-free survival. The addition of taxane increase of both the overall survival and disease-free survival or progression-free survival. Among women those women which are not positive breast cancer, and this is very important point. These patients that are not positive breast cancer, they have increased the overall survival and progression-free survival with the use of taxane. Yes. And accelerated every 2 weeks treatment, what is called dose dense. Dose dense treatment, that is to say, use of every 2 weeks treatment of chemotherapy, lower the risk of recurrence and improve the survival. There are many trials to add further chemotherapeutic agents like the capecitabine or gemcitabine to anthracyclines, and taxane-based chemotherapy regimen has not significantly improved efficacy. For women who need chemotherapy, sequential use of anthracyclines, so the sequential use of anthracyclines to be followed by taxane, considered as the gold standard for patients with adjuvant chemotherapy. Now, what are the side effects of chemotherapy for patients with breast cancer and the use of these chemotherapeutic agents? Various chemotherapy regimens have distinctive side effects profile that can inform regimen selection for an individual patient. For example, the anthracycline has side effects mainly as cardiotoxicity, but these associated with low risk of cardiomyopathy and may not be appropriate for patients with previous use of anthracycline exposure or pre-existing cardiac disease. Of course, the doxorubicin has cumulative dose that should be calculated when the use of this treatment for the patient. Taxine also has side effects, and these may be the taxine that cause uh, what is called neuropathy. So, the selection of these drugs, which are the taxines, should be carefully for patients with neuropathy, like diabetic patients. Anthracycline is used in specific study, what is called ABC study, and this ABC study in early breast cancer compared the outcomes for women receiving anthracycline-based regimens such as AC followed by taxane uh, in comparison with what? In comparison with the use of taxotere, that is docetaxel, with use of indoxan, that is cyclophosphamide, in women who are HER2 negative cancer. In these women, this study, these women use the comparison of AC followed by taxane or docetaxel with cyclophosphamide in HER2 negative breast cancer. The anthracycline-based regimen yield better overall results, particularly in those patients who are high risk node positive cancers and ER positive cancers and in triple negative breast cancer. So according to this ABC study, the anthracycline-based regimen gives good results for specific patients, especially those with are the higher risk patients who are not positive and those which are triple negative breast cancer. Now the question, does every patient need chemotherapy? This is very important question. The answer, of course, not all patients need chemotherapy. Although chemotherapy leads to statistically significant risk reduction, the differences in the absolute risk recurrence for patient it is small for patients who have small cancer or ER positive patients. Now, another question is what is the predictor benefit from chemotherapy? So, what is the predictor of benefit from chemotherapy? The hormone receptors status is an important predictor of benefit from chemotherapy. The hormone receptor is very important. What are the hormone receptors? Of course, the ER and PR receptors. It is found that all triple negative breast cancer that get benefit from chemotherapy, and also the node positive breast cancer. So in triple negative breast cancer that the patient has ER, PR and HER2 negative get the most benefit from the chemotherapy, and also in the patient with the node positive and or if the size of the mass more than 0.5 centimeter. Okay, so all these features, when the patient has these features, get benefits from chemotherapy, other than other patients. Now, about the endocrine therapy of the patient. Endocrine therapy, two main drugs for hormonal receptor positive breast cancer, and these hormonal receptor either ER positive and or PR positive patients. These two types of endocrine therapy are tamoxifen mainly, which one of the drugs was called the selective estrogen receptor modulator. These are serum. And the other group, the main group, which are the aromatase inhibitor drugs, which include two groups, which are either steroidal like anastrozole or non-steroidal like exemestane. The gains associated with tamoxifen are achieved are independent of the patient age, so the age is not important for the use of tamoxifen, and also the menopausal status, with or without the use of adjuvant chemotherapy. The tamoxifen characterized with what is called a durable effect. A durable effect contributing to improve overall survival for at least 15 years, okay, on follow-up of the patient. Shorter durations of tamoxifen therapy are also beneficial but appear to have less impact than 5-year treatment duration. So the treatment of tamoxifen is for the 5 years. Until recently, data has suggested that the optimal duration of tamoxifen therapy was 5 years. But there is what is called Atlas trial. In Atlas trial, which is the adjuvant tamoxifen longer against shorter trial, compared 10 years over 5 years, 10 years over 5-year use of the adjuvant tamoxifen, and it's found improvement in overall survival and disease-free survival. With the longer duration. The finding is of particular relevance for the premenopausal woman based on the Atlas trial. Premenopausal women should consider longer duration of tamoxifen up to 10 years as adjuvant endocrine treatment. Of course, tamoxifen is not effective in preventing recurrence of hormone receptor negative breast cancer. Should be ER positive and or PR positive breast cancer. Now, the question is what are the side effects of endocrine therapy? Of course, no drug without side effects. Tamoxifen associated with what? Tamoxifen associated with thromboembolism, and also increase the risk of endometrial hyperplasia and endometrial cancer. While aromatase inhibitor, the side effects mainly is accelerated atherosclerosis, accelerated the osteoporosis. Greater risk of bone fracture also, and also it causes arthralgia syndrome. The patient receiving aromatase inhibitor therapy require serial monitoring of bone mineral density. We have to do DEXA scan for the patient before the start of the use of the aromatase inhibitor. Both treatments are associated with what? I mean, the tamoxifen and aromatase inhibitor are associated with what is called menopausal symptoms, and these such as the hot flash, night sweats, and genitourinary symptoms, including the sexual dysfunction. All these features could occur with the use of endocrine therapy, whether tamoxifen or aromatase inhibitor. Postmenopausal women who are intolerant to either tamoxifen or aromatase inhibitor therapy should be offered to alternative type of treatment. And because aromatase inhibitor therapy is only effective in postmenopausal women, tamoxifen remains the treatment of choice in women who are pre or perimenopausal or in whom there is a question of residual ovarian function. But of course, aromatase inhibitor can be used for premenopausal women in association with what? With LH-RH agonist. This used for the ovarian function suppression. Another group of drug that is used in patients with breast cancer, which is called bone modifying agent. These bone modifying agents are two groups of drugs mainly, which are the bisphosphonate including many drugs like the zoledronic acid, and the second group is the what is called Tamoxifen. Both these agents can cause side effects like hypocalcemia and osteonecrosis of the bone, but with different degree between these two drugs. These decrease the loss of the bone density in women with treated induced ovarian failure or on aromatase inhibitor therapy. In addition, there are data that bisphosphonate, like the zoledronic acid zometa, can reduce the breast cancer recurrence in postmenopausal women. The other group of drugs, which is very important for the management of breast cancer, is an example of the monoclonal antibody drug, which are the drugs that are used for HER2 positive breast cancer. These drugs for HER2 positive breast cancer, these include the Trastuzumab mainly, which is the Herceptin as known. This should be used for the patient with immunohistochemistry results showing 3 plus of the HER2, or for the patients which are diagnosed by in situ hybridization. The in situ hybridization include the fluorescent in situ hybridization, which is the FISH, or include what is called the SISH, which is the chromogenic in situ hybridization. The Trastuzumab may be used for the patient as adjuvant treatment or also in the patient with metastatic breast cancer showing HER2 positive. For the use of Trastuzumab in the adjuvant patient, it is used for 17 cycles. That's to say, 1 year for the patient with HER2 positive breast cancer. But it carries the risk of cardiomyopathy, which is a novel side effects, that is reversible side effects. Cardiac dysfunction is more frequent in patients receiving anthracycline than the patient that non-anthracycline adjuvant chemotherapy. Other risk factors for cardiac dysfunction with adjuvant trastuzumab in presence of pre-existing cardiac disease. So, for patients with the use of trastuzumab, the ejection fraction is very important to be seen before the use of this drug and follow-up of the patient, especially for the patient that are older age, more than 65 years, should be close follow-up of the patient, and the risk of cardiomyopathy is increased. The optimal duration for trastuzumab is 1 year, although shorter exposure that are 9 weeks is used in certain studies, and it is found also beneficial than without use of trastuzumab in patients with HER2 positive breast cancer. In HERA trial, there was comparison for the use of trastuzumab whether 1 year or 2 years, and it is found that there is no benefit for the increase of the use of the trastuzumab for more than 1 year. Now the question is about the trastuzumab. Is the use of trastuzumab active with chemotherapy or after the use of chemotherapy? Trastuzumab is active when delivered sequentially after chemotherapy, as done in HERA trial, or concurrently with the chemotherapy, as done in NASAB trial. And this NASAB trial is the National Surgical Adjuvant Breast and Bowel Project in B31. It's found that is sequential is effective. And also another trial that is North Central Cancer Treatment Group. Also, they compare the use of the sequential or concurrent trastuzumab. However, concurrent trastuzumab and chemotherapy administration yield superior results compared to sequential therapy. All of the adjuvant trastuzumab trials gave chemotherapy. There are no data whether trastuzumab would be effective without adjuvant chemotherapy. Now another question, what is the optimal chemotherapy backbone? What is the optimal chemotherapy backbone for trastuzumab based adjuvant chemotherapy? When we use the trastuzumab in the treatment, what is the best chemotherapy to be used? The optimal chemotherapy backbone for trastuzumab based adjuvant treatment is uncertain. Most patients treated on the extent of clinical trial received sequential anthracycline with use of the indoxacarb cyclophosphamide, followed by the taxane with the use of the trastuzumab, with concurrent use of trastuzumab during the taxane treatment. The results from Breast Cancer International Research Group this is the Breast Cancer National Research Group suggests that the use of non-anthracycline trastuzumab, docetaxel and carboplatin, that is TCH regimen, is superior to chemotherapy without trastuzumab. This is superior to chemotherapy without trastuzumab. So TCH is an important treatment option, particularly with patients who have contraindication to the use of anthracycline based treatment. Thank you.